it really did seem to be its own pattern, and it was super severe. And most patients really do endorse, they'll tell me it's different than my eczema. It really is fundamentally different. The symptoms are different. It looks different. It's in different places. Like after 7 or 8 of them, I'm like, okay, wait a minute. Like this really does seem different. I don't think these people are crazy. These people were very earnest. Like nobody was trying to get attention. Nobody, there's no making money. Nobody's writing a book about it. Like this was real.
Hey everyone, today I am here with the amazing Dr. Peter Lio. In the cold north, I get to be in the south, but we are here today to talk about TSW. And I met Dr. Lio many years ago. I think the first time we actually met in person was 2019 at an eczema expo where you were speaking. And I have to say, I think of all the doctors who are out there, I think you are one of the most beloved in the eczema community. You're the doctor of doctors, the kind of doctor everybody hopes for when they go in to see someone. You listen to your patients, you really care about them, you work with them to try to find solutions, and you have been a real ally and friend to the TSW community for a very, very long time. So I just want to say thank you so much for your work in this space, especially when others were not willing to speak up and publish and really push in the system to try to move this forward. You have done so much. You've helped us with trying to get an ICD-10 code by presenting to the CDC. You publish many papers on TSW. You are constantly working and thinking about the patients that you serve. So you're just an amazing guy. And we're so happy to just be talking to you today to get some more information about your experience with TSW in the clinic. So I'd love to throw it over your way for you to give us a little bit more of your professional background. Tell us who you are, what your work has been, and how did you get involved in this whole TSW scene?
Well, thank you so much for having me, and thank you for the kind introduction. I'm a dermatologist. I've been in practice for over 20 years, and my focus the last really 15 years has been all on atopic dermatitis and the eczemas kind of as a group. So that's pretty much my whole practice. I have worked closely with the National Eczema Association for many years, and I run a center in Chicago called the Chicago Integrative Eczema Center. So I'm really interested in integrative and alternative approaches to treating a lot of inflammatory things. And that kind of traces back to my studies where I learned about acupuncture. I spent a full year studying acupuncture, and that was fantastic. And I really love thinking outside of the box. So it's been an adventure. In terms of TSW, I do have a fairly large group of patients who come to see me kind of from all over the country and actually even all over the world. And it is one of the most challenging things that I treat. I mean, I think the patients that I've seen are struggling so much and they are trying so hard to get better and they're open to anything because they really feel like they're at the end of their rope a lot of times. So I really have been focused on how can we help, of course, prevent it from happening anymore. But for the patients who are suffering and struggling, what can we do? Can we pool all the resources? And I've been lucky enough to work with some great people to write several papers on it, including one just in the last year with Olivia Friedman about traditional Chinese medicine approaches as well, which I know you know a lot about as well. So really neat to think about how we're finally getting some traction with some new ideas and new understanding, although boy, we have a ways to go.
Yes, absolutely. Well, okay, let's get started. I'd like to ask you, what changed your mind about TSW and even believing that this is a real condition? When did you start seeing, okay, maybe this is something different than eczema?
Okay, so this would take us back more than a decade ago. This would be like 2013,
Mhm.
2014. I was starting to see patients who had heard about this online. And back then, I think the online situation was a little bit different. It was a little bit more, I think, kind of angry at doctors and sort of blaming. And that's always a tough way to enter a room, right? You can imagine most of our patients come to us looking for help and support, and it's hard when a patient's really just mad. They're like, you basically, you all
Yeah.
have done this to us. And it's kind of
Yeah.
like, wait a minute, I just got here. I don't know. Like I did, most of the patients I hadn't seen before. And interestingly, even though I had taken care of eczema patients for already many years, I had never seen, at least to my own knowledge, and it's possible that I've missed some of these patients over the years, but I don't think I've actually seen TSW develop in my patients that I had noticed. Now, looking back, I think probably back years and years ago, there were some patients that I think probably would qualify for it, but I
Mhm.
wasn't aware of it in that way. So patients would come from outside with this kind of self-diagnosis of it, and it really was tough. And it was kind of like, well, I think this is something they would say, I think this is TSW. I don't want any steroids, and I'm very angry at the system, and I want some help. So it was tricky because the first thought is like, well, boy, this really does look a lot like severe atopic dermatitis. And almost all the patients I've seen came from a history of severe atopic dermatitis. So I think my initial sense was, are we sure this isn't just bad eczema that we're kind of just blaming steroids on?
Mhm.
But after maybe the seventh or eighth patient, where I started to see some more stereotyped stuff, I mean, it really did seem to be its own pattern, and it was super
Mhm.
severe. And most patients really do endorse, they'll tell me it's different than my eczema. It really is fundamentally different. The symptoms are different. It looks different. It's in different places. Like after seven or eight of them, I'm like, okay, wait a minute. Like this really does seem different. I don't think these people are crazy. These people were very earnest. Like nobody was trying to get attention. Nobody, there's no making money. Nobody's writing a book about it. Like this was real. Like, you know what I mean? And
Yeah,
and they weren't crazy. This was people with real inflammation, real suffering, and a real pattern. So after that, I said, I better start learning more about this. I dug into the literature. It turns out it wasn't something that nobody had ever heard of. There was a literature
right,
about it, right? And that's the other weird misconception about this. I'll talk to people and they'll say, well, why isn't there any articles? I'm like, why aren't there any articles? There's 100 articles. There's so many articles. I mean, maybe
yes,
they're not ones you're seeing, right? But they're there. All you have to do is nowadays you just Google Scholar search and you can see
right.
50 on the first page. So then we started writing more about it. And I think I'd like to believe, and I think to some degree it's true, we've increasingly moved towards a better understanding and better acceptance of it. But I'm fully aware that, and I still meet people that are kind of like, well, I don't believe it. And I'm like, you don't believe it? I don't know if this is now a thing of belief. This is not the Santa Claus or the Tooth Fairy. This is a real disease affecting real patients that is now recognized by several
Right.
countries. Like it's on
Yes.
in the UK and in Canada. It's like specifically called out. So belief is probably not an option. Belief or not belief is not an option anymore. You kind of have to. Maybe now the question is we just got to better understand it.
Yes, great point there. So, along that line, how does TSW look different? How is it different than eczema or severe
So
eczema?
thank you. I think that's the key question, and that's the hardest question.
Mhm.
But the key things are the biggest things to me, the most striking are there are some signs, and we have to give a lot of credit. There are many people who are behind this. Of course, Marvin Rappaport was doing this long before everybody was even talking about it. So Dr. Rappaport was
Mhm.
ahead of the curve by 20 years. So we have to give him his credit
Yeah.
for sure. And then I give a lot of credit to Belinda Sherry. She's in Australia. She's a wonderful doctor who has all these patients and did some of the first papers describing these signs. And again, it's always difficult when you're talking about something new. You have to coin the term. You have to actually create a new idea. And so she really helped a lot of this and bring these out. And of course, we have to also thank the community because a lot of the patients drove this. And that's the other weird and exciting thing about TSW, right? I always tell this story. You've heard me tell it many times, but for a dermatologist, 99.9% of my life is people coming in saying, what's this spot? What's this rash? What's this thing? I don't even know. Oftentimes crazy, like we'll get like another service in the hospital, like cardiology, a patient's in the hospital for their heart surgery or something. And the cardiologist calls and says, I don't know, they got some kind of a skin bump or something. Just come over. And you're like, this is a drug rash. Like what? It's a bump. Like I thought I was going to
Yeah.
look at a growth. It's a rat. Like totally crazy. So we're usually the ones putting names to things. Here, the patients really drove so much of the understanding, the nomenclature, and really identifying this disease. And that's also a little bit tough, I think, for some dermatologists. Like, wait a minute, I'll tell you what it is. You don't tell me what it is. So
Right.
there's that little piece. But again, the patients divine so many of these terms. So things like I think the most striking one, and I love showing this in my talks. And again, I have to thank Olivia Friedman. She gave me a lot of the great pictures. I have some of my own, but she's had so many beautiful pictures of this that she has shared kindly. But the sleeve sign, where
Mhm.
you see this eczematous confluent erythema and like lichenification, skin change, eczematous change that cuts off sharply at the sleeve. It's
Yeah.
really weird. It's
Yeah.
really unique. Or the elephant skin sign, where we see this kind of almost like a laxity of the skin, but we've biopsied this and looked into this. It's not cutis laxa. It's not mid-dermal elastolysis, right? There's other things that might look like this. It's not some kind of elephantiasis. It's its own thing. So these specialized things are very unique. And then, of course, we also have some signs or some symptoms rather, that are important too. People often feel this kind of prickly sensation, sometimes called zingers by the patients, which I think is a really neat term as well. A paresthesia or neural sensations. A lot of temperature instability is really important too. So these are all key things that we've seen. And then to me, the most important part, and this is what I think is the most teachable for everybody because it also helps us prevent it, but it's that history of increasing corticosteroid or escalating corticosteroid requirement where it's not working as well as it used to, and people keep going up and up and up. And that's often when, in my experience, it seems to start like it's kind of almost at a corticosteroid addiction piece. And then when we stop, all heck breaks loose. So
Yeah.
to me, that historical piece is part of it too. That's kind of how I'm thinking about it. And we have a paper that
Yeah.
talks about some of these, and we did a Delphi method. So people, many dermatologists and providers, including Olivia, she's on that group, have agreed on these. We've all come to consensus that these are key pieces. Now, is it the same as a vetted diagnostic criteria that we've done a randomized, proactive trial or something? No, we're not there yet. But this, I think, is a really good start. It really codifies the language.
That's amazing. Thank you for that. That was really comprehensive. I want to add in there too the burning piece because that was something that was so different than just regular eczema, especially because I was starting to recognize it in my hands while I was still using steroids. But it was when I stopped with that, it just covered my entire body, literally feeling like someone had poured boiling water over me. I mean, it was just really, really painful. So that was not eczema. For sure. So, what are some of the warning signs? You touched on it just a little bit on, needing higher and higher potencies or needing to use it more and more. What are things that people should be looking out for if they're using steroids to treat eczema?
I think a couple things. First is right, it usually is eczema, and that's important to know. I would say it's not exclusively eczema. I think there are
Mhm.
people that had psoriasis or contact dermatitis or even things
Right.
like rosacea, but mostly eczema patients who were thinking about it. We're looking for that increasing need for steroids. And to me, my rule of thumb, and part of the reason I'd like to think, I might be wrong, but I'd like to think that I don't see it happening spontaneously in my patients very much at all, is because I lock and limit the amount of steroids. So I'll tell patients you're going to use your steroid for a little bit, but then you have to take a break. And I often say my rule of thumb is in a given month, you shouldn't be using a steroid anywhere on your body more than half the time. So for 14, if your 14 days are over, we have to make a change, right?
Mhm.
So the easy version, just to make it clear, a milder patient would say, you know what, I have a little eczema. It gets my elbows, maybe on my wrists. It gets a little itchy in the winter, especially. I use my steroid for a few days and then I'm good for a few weeks. It's like, gosh, that's great. That patient who has barely tucked into their 30-gram tube, they've used a quarter over 2 years and they're like, is it expiring? It's like, your risk is near zero. Now, is it zero? I don't know. There are some people that seem to have a very, very intense reaction to steroids, but I think from a population standpoint, that's going to be about as safe as we can get. No medicine is perfectly safe. There's always potential side effects. We
Right.
know this, right? Whenever we tinker, there's side effects. Even water, this has side. You can die in water, you can drown in water, you can overdrink water. Everything potentially has issues, but that's about as safe as you can get. As you start pushing that point and you're on them more than you're off them, I think then you start to see a real risk of danger. Of course, there are some side effects that are much more accepted, things like skin thinning and atrophy of the skin. Littler kids, especially, can
Right.
absorb steroids. Now you start getting systemic absorption, which has tons of terrible things. I mean, we know this is not a good thing for your body. It affects your blood sugar, your blood pressure, it affects your bones. It can make you susceptible to infections, all these terrible things. So that's absolutely a no-go. So the difference is what do you do when you are encroaching that line and you say, okay, now we're using it 15, 18, 20 days a month
Right.
instead of here's another prescription for triamcinolone. Good luck. You just have to keep using it, which I don't want to hear about it because I know people say that to patients. I've had other colleagues say, no one says that. I'm like, oh, yes, they do. I've had many patients tell me exactly those words. They say, well, you still have the rash. Keep using it. Good luck. That's
Right.
terrible advice, right? That's dangerous.
Yeah, and it's really like I always think about it as a slippery slope because if you have a chronic condition, it's if it's being caused by something in your environment, that's not going to go away. Your steroids will, tamp down the inflammation, but then the minute you stop, it's right back. So I remember thinking that like, okay, this medicine doesn't really have a dose on it, and it just says use on affected area as needed. Not more than 2 weeks, but I always think, well, don't use it on the same spot for 2 weeks instead of don't use it on your whole entire body for 2 weeks. I didn't realize it was a hormone. I didn't realize hydrocortisone was a steroid. There were so many things that I didn't know. I didn't realize that steroids are cumulative in their effects. So the longer you use them, the higher potency you use them, the higher your risk. It never occurred to me. I just figured they were perfectly safe. And some of our people in our community have gotten like these 1 pound jars. And so it's like, well, what do you do with that? You're going to use it. If you've got a rash, you're going to use it. It works like a charm, right? So a lot of it is just awareness. And I like how you say you have it kind of locked of the use and what you guide patients because so many people are just not given any guidance. They're just given the prescription and sent on their merry way. And I think it's partly on our side as patients too, it's like we want a quick fix and something. Steroids are super cheap. They're easy to get a hold of and they work really fast. So it's really nice. I remember as a teenager when I first started using them, I could eat whatever I want, do whatever I want. As long as I had my trusty tube of tridesolone with me, I was just fine. I wasn't really thinking beyond that. So I'm so glad that we're here now today where we have so many different options. There's so much more information out there for people that they can get a hold of. And I would, well, I'll go into that a little bit later, but I wanted to ask the next question is, what are you seeing as far as treatments that are helpful for people who are dealing with TSW now? So I know you have an integrative approach, which I totally love because I think that's what people really want. They would just want to know all the options and then figure out, okay, what's best for me? What makes the most sense or what works for me? So like between Western, Eastern, naturopathic, I mean, this is a slew of paths people could go down. What are you seeing as being effective and helpful and maybe some options for people to consider?
Yes, we have a huge paper about to publish where we've kind of culled a lot of the data on this. So it's not, I wish I could say we have the answer to it. We absolutely do not, but we have a list of sort of the things that have some studies and some evidence, and then a list of a lot of things people are talking about with a little bit of an explainer on it too, because I just kind of want, mostly selfishly, I just want a cheat sheet that I can talk to my patients about and show them. We can kind of go through it. And interestingly, there are lots of things being added, but I'll start with the big four. There are kind of four major things that I think about first. I mean, the first piece, of course, is avoiding steroids. We really want to cut steroids out completely, and we don't want them in any form. We don't want inhaled steroids. We don't want eye drop steroids. We don't want nasal steroids. I mean, they're kind of all over the place. So you have to be a little bit careful on that. I do always tell my patients, God forbid, if you were in a life and death situation, like if you had anaphylaxis and the ER said we have to give you steroids, in that case, I would say, yes, take the steroids if it's life or death. We will deal with the repercussions of that. But other than that, for eye issues or nose issues or anything else going on, if we can, and most of the time we can, thank goodness nowadays, we can say, let's not use steroids. Okay, so that's kind of above this whole list. But then what if you already have it? Okay, first thing, number one is cyclosporin. And that really was the one that Dr. Rappaport has been using for more than 20 years. It is a powerful immunosuppressant. It is not perfectly safe by any stretch of the imagination, but it's pretty helpful for a lot of patients. And it's something we also use for severe atopic dermatitis, carefully monitoring people, watching their kidneys, watching their overall health. We can really make a difference for a lot of patients. So cyclosporin is common.
Mm-hmm.
My number two is one I've written a little paper about. We had a case series of patients, and that's dupilumab, or the trade name Dupixent. That's a biologic agent. It's kind of a little more targeted, or I should say a lot more targeted than cyclosporin. Cyclosporin is kind of knocking your whole immune system down, not as much as steroids, but
Mm-hmm.
pretty big. The Dupixent is very targeted. It's just blocking more of this allergic inflammation pathway, and that really does seem to help a lot of patients. Is it a cure? I wish. No. Does it help everybody? I wish. Nope. But most patients that I gave it to seem to get some improvement, which is something. These are patients who are often miserable, and we've tried a lot of things, so that can be helpful. And Dr. Miles, Ian Miles's recent paper suggests that at least the patients he's seen with TSW have crazy high levels of IL-13, that immune cytokine that signals itch and inflammation for allergy types, which we see in eczema as well. And that's exactly what Dupixent's doing. It's blocking some of that IL-13. So it really does, as best we can say, to some degree, get to one of the root causes of this potentially. So number one, cyclosporin. Number two, Dupixent or dupilumab. Number three is phototherapy, light therapy. So a lot of my patients are kind of skeptical of any drugs. They don't really want any kind of medicines. Like, look, I've been burned already. I don't want to deal with any of this. So the power of light is amazing. Now, this is not red light therapy. A lot of my TSW patients are like, oh, I'm already doing that, or we have a home unit. Red light's different. Red light may help. There's not a lot of evidence for it. It certainly won't hurt,
Mm-hmm.
but it's not the same. We're talking about ultraviolet B, narrowband ultraviolet B light. So this is a prescription type item. It's in a doctor's office, or you can get a home unit, and you actually, it looks like a tanning booth, and it treats your whole body. In my experience, especially if it's not super bad, if it's super bad in terms of inflammation, it sometimes is just not going to help, and it can even make things worse. But if they're not too bad, it can often bring down the inflammation. It boosts your vitamin D. It helps your microbiome. It's really a good holistic treatment. I love it, and it's one of those great treatments in dermatology. And then sort of the last little bit, it ends up being a little bit of this more experimental stuff. Where do we go in terms of experimental? And there's a lot of things. So there's other biologics like the nemolizumab or Nemluvio. We have, of course, the alternative pieces like traditional Chinese medicine, which I've had a lot of experience now referring patients to Olivia and seeing some really good improvements there. We have some other whole body treatments, things like cryotherapy. So then it kind of starts to branch out a little bit, and that's where it
Yeah.
gets interesting. And then there's been a few new things like you saw in Dr. Miles' paper, berberine, metformin. People are talking about lots of stuff. So in this paper, when it comes out, we'll be able to look at the whole list.
Okay, so I wanted to also ask you about your thoughts on acupuncture with TSW because we had several people actually on our board who used acupuncture during that season, and they said it was the one place that they didn't feel any pain. And I thought that's really interesting. I didn't do acupuncture when I worked with Dr. Friedman. She was saying, well, the herbs I think are going to be what are most helpful. So I just went that route. But because you studied that, I'm curious to hear your thoughts about how that could be helpful and why.
I think acupuncture is great anytime there's, especially if there's pain, and you mentioned that burning sensation more than
Yeah.
itch for a lot of patients. So pain, it can be very helpful for anything that's triggered or driven by stress. And we definitely see that with both eczema and TSW. When you're under stress and you're not sleeping well, that can kind of make everything worse. So the
Mhm.
acupuncture can kind of help normalize. In my own sense of it, it's probably not enough to do very much on its own, but it's a really nice adjunctive treatment. One of
Mhm.
the hard parts is if you're doing a lot of things at once, for some of the patients that I see there, it's hard to get out of the house because they're sick. It's very tough to
Yeah,
move around. So I try to be a little bit parsimonious about recommending too many things because I feel like that's the other danger. It's like, oh, do this and this and
right,
this and take this supplement and go to kappa therapy and get, it's like, okay, I just am trying to get out of bed. Like I'm
I
miserable and
know.
uncomfortable, so I think acupuncture can be an adjunct in the right setting, but it's not one of my top 4 or 5 because
Yeah,
it's more adjunct.
thank you. So, when you're sick with TSW, you're trying to get through it, you're recovering. I know I was bedridden for some time. You are just like crazy looking into the information and trying to find the answers, trying to find help, trying to find good information. I wanted to ask you, where are good sources for people to look? Because right now on social media, it's just a total mess and chaos, and you don't know what's real and what's not. How can people know that they're finding good material? Like you're talking about this paper you're just getting ready to publish, which is amazing. But where do people find things like that? Like if it's just the regular person, they're not connected with, Dermatology Times or these different, they don't even know what the journals are. Could you help people understand where do they find that?
I think ITSAN will be a great clearinghouse because you guys, of
Mhm.
course, have great information there. And I know you keep a social media presence where you're sharing some of the new things and
Yeah,
also giving some context because that's the other thing, if out of context, it's like, oh, berberine is the cure. It's like, well, that's not what Dr. Miles said. That's not what the paper showed. It's like, so you need some context a lot of times, some discussion.
right.
So I think those are great places. The paper that we're about to publish will be open access, which means anybody
Good.
can find it and read it, and there's no fees or
Awesome.
anything, which is really cool. I love stuff like that.
Mhm.
I'd like to say that National Eczema Association, we have some information on there. I'd like to do better on that, but there's definitely some discussion on there that I think is credible. But it is true. It's kind of a wasteland. And honest to goodness, this is true for almost anything in
Yeah.
health. But especially more newer things and things that are less stable. It's like, boy, you're really in the Wild West.
Yes, it's hard to know. So I wanted to ask this question, especially because of some of the conversations I've heard in dermatology about all the misinformation on social media and people are misdiagnosing themselves and it's dangerous, all of this. Okay, so I'm sure that's the case in some scenarios where people could be misdiagnosing themselves. Could you help us understand what are some conditions that may have similar symptoms or mimic things that people are seeing as TSW online that people should be aware of and maybe go and get certain tests to rule out?
For sure. There are a few things that I think are important to call up. The first most important one, and I even confess that I can't tell for sure that it's not just super severe refractory atopic dermatitis, right? Because that's real. Super severe eczema can look just like this, and honestly, we would treat it kind of the same way. So
Mhm.
that's important. The other big one I think that we have to think about is the one called cutaneous T cell lymphoma or CTCL. Cutaneous T cell lymphoma can look like a refractory eczema, and they can present with redness all over. They can have tons of peeling, like it can be similar. And the only way to diagnose that one is typically with multiple skin biopsies because it's one of those tricky ones to diagnose. It kind of masquerades as eczema for sometimes years. So that's the other one that I think we have to be on lookout for. Another big important one is contact dermatitis. So you could be allergic to literally your steroid itself or some component of the steroid cream, maybe the preservative, maybe the base, or your moisturizer, right? So you're putting on a moisturizer or your soap when you wash with it. So you could get a pattern where it could look very similar to this if you're allergic. And one of the things we do for that is we test the patch test. We put those little tiny stickers on your back with a little bit of each chemical in there to see if you react to it. Now, sometimes it's really hard if you're beet red and oozing and open. It's like, we can't do the
Yeah.
test. But that's another important thing. So a lot of times I'll try to cut off a lot of the unnecessary things. And I think that's probably why no moisture therapy, that NMT concept, may help some people, especially because if they're allergic to some component or even just irritated by it, by cutting off everything from their skin, that may help them heal, which can be reasonable. I don't love NMT because part of the full discussion is not drinking enough water, which makes me real nervous. I think it could hurt your kidneys. So I'm okay with cutting moisturizers if you want to experiment, but I do like people to keep hydrated because I don't want to have permanent damage to the kidneys. So those are some of the big things. Psoriasis can also look like this as well. Scabies. I had a patient a few years ago that thought they had super severe eczema, treated with all this stuff, then thought they maybe had TSW, but it didn't really fit the pattern. And sure enough, when I looked between their fingers, they had burrows. I did a scraping, and sure enough, they were covered in scabies mites. So we
Eee.
treated their scabies infestation, and they were cured. So that was a
Wow.
wild case. I'd seen multiple dermatologists. It's not as easy as a diagnosis as it might seem. It is very possible to miss it. And then there are even some genetic conditions, things like Netherton syndrome and so on. So there's a list. It's in our upcoming paper. We have a kind of an exhaustive
Good.
list of things we considered and some of the testing you can ask for. Because my
Hmm.
biggest fear, and I'll tell you this is interesting too, though. I have not yet seen a patient who really felt confidently that they had TSW, that I felt they had TSW, that had something else. Like it has been
Wow.
ridiculously on point for these patients, as
Wow.
opposed to other things. Eczema sometimes like actually this is more psoriasis, or that scabies patient, they really thought they had eczema and they were worried about TSW, but it was scabies. So interestingly, I think that for whatever reason, this is quite well targeted for the patients. That they really are reading about it and thinking about it very wisely. But still, it is wise to check to make sure there aren't other things. And especially as it gets more widely known, it's possible that definitely I get some families with a young child who says, I think could it be? We're worried about it. And I'll look, I'll say, really, these there's two little patches. I don't think so. But my take home point, if I can't say it enough, is even for that family who I do not think has TSW, they barely use steroids. It's not even that bad. I still respect it. And I say, you know what? Why don't we just stop steroids? Why don't we just not, let's just not even play with it then. If you're worried about it, then I don't want you to worry about it. We have now non-steroidal medicines. Now, does
Mhm.
that just mean I'm shilling for big pharma with more expensive drugs? No, it doesn't, because some of the things I'm talking about are natural treatments where, I don't know, there's not a big coconut oil or a big sunflower oil company that I know of. I don't, if there is, I don't know of them. I can tell you to go to your Whole Foods and get something or go to your grocery store. So we can do other things, or this would be a place where maybe we would say for more mild disease, why don't we try traditional Chinese medicine or acupuncture or another approach? And if they need something, of course, we do have some non-steroidal agents that are really great, that are quite different. So all these new things that are non-steroidals.
Yeah. Okay. Wow. Um, so I love that the paper is coming out. That's going to be extremely helpful. We will share that very broadly on different options that people are seeing are helping, and then different tests that people should take for specific conditions that may be something different than TSW. I also wanted to ask you, what are some potential complications that could arise during TSW that people need to be aware of, and when would they be aware of those things? What would they be looking out for?
The big complications, and there are many because these patients kind of have, we could consider them severe eczema at baseline. Plus, it's like eczema, terrible eczema plus. And
Yeah.
I would say, the infections are huge. So bacterial infections like staph, eczema herpeticum, where you have cold sore, which might for somebody without eczema have just be a cold sore on their lip or their face. But then for eczema and TSW patients, it can spread all over. It can affect their eyes. They can get extremely sick. You can even die from it if it's untreated and it gets severe enough. So it can be life-threatening. Of course, we know that the temperature instability is really hard on your body. Some patients, there's this question, could they have this sort of Cushing's disease initially, where they've overexposed, and then switch to Addison's disease, where they're now not making enough steroids in their own body, which is
Mhm.
also interesting. And that could be, again, life-threatening. If you're not able to make we make natural cortisol. It helps balance our body. It helps keep our blood pressure up. It's a stress hormone. So if you can't make it anymore, if you've been exposed to so much, it can be life-threatening as well. So all of those things are real. And I'm worried about them from the beginning. As soon as I see these
Yeah.
patients, because I would argue by definition, they have already gotten beaten up a lot.
So, what should people be looking for? Because I know in my case, I was bedridden. Many people are stuck at home. They don't want to see a doctor. I only went out when I absolutely, absolutely had to because it was so uncomfortable and I'd get labs done or whatever. But when should people be concerned? Like, what types of symptoms that should they look for an infection? And then maybe some of these things like cortisol insufficiency.
Yeah, I mean, I think for infection, it's going to be new open sores, painful spots, abscesses, like you have a big pimple that's not healing, or lots of little pus bumps that are appearing. The eczema herpeticum often looks like little sores that appear. It often is more painful. So anything like that, I think you want to go in. Unfortunately, a lot of the symptoms of things like Addison's disease are very much what we're seeing with our TSW patients anyways. People feel exhausted, like they can't get out of bed. They have some temperature instability. So all these pieces. So I kind of feel like everybody needs to be checking in if they feel like they have TSW beyond is anything beyond the skin. If you feel tired and exhausted and run down, of course, if you have a fever or anything like that, you really need to get checked over.
And so they should get tests for what in that case?
So the question is do we test, should we test for Addison's? And there are some ways to test for it. I think the biggest piece is if they feel like they are not able to get out of bed, and feeling that level of rundownness, then I think they probably should. I
Mhm.
had tested a few patients early on and we didn't see anything. And one of the confusing parts is there's different tests for it, but one of the tests was a cortisol stim test. So they wanted to give the patient some steroid to
Mhm.
kind of see what
Oh,
happens. And my
wow.
patient didn't want to do that. I don't know. So it's
Yeah.
unfortunately it's out of our area, so you have to usually refer to an endocrinologist. So I would
Mhm.
love to get some good endocrinologists involved with ITSAN too to help us understand when
Yes.
we should do it because it's been a little bit trickier.
That I love that idea a lot. And I love your recommendation for people to go in and get seen, even if they are uncomfortable. And the more TSW is talked about and kind of normalized, that people realize, okay, this is a thing, I think people will feel more comfortable going in. But there's a real fear. It's crazy. I think just because there's been some dismissal, you already are suffering, and you feel like if I go in and I get yelled at, or, kind of talked down to by my doctor, it's going to make everything worse. It's like people can't emotionally handle it. And so to have an environment change in the medical community where there's more of an acceptance for people so that they feel comfortable going in and then working together with their doctor, this is a great segue into the next section I wanted to talk to you about. If people are concerned about this, how should they approach this topic when they go in to talk with their doctors? Because we're still at a place where it's not very familiar. Some are still thinking that this is like downright not a real thing. It's an internet myth. There's still that mindset in some places. So, what would your recommendation be for patients and for caregivers when they go in? How do they bring the topic up? How do they talk about it in a productive way?
I think it will vary on each person. So I wish I had a one size fits all, but I think trying to connect with your clinician, explaining to them where you're at, I'm really miserable. I've had so many steroids. I really don't want to use any more steroids. I understand many people feel like that's the right answer here, but I've been on so many. I'd really like to do something different. And if you can bring a paper about it, that would be great. Sometimes that can be nice and non-threatening. It's like, I read about this. Would you have a look at this? What do you think? If it's a
Yeah.
reputable paper, and this will be great, this will be in the British Journal of Dermatology,
Right.
kind of hard to just dismiss that, or you could do the one from 15 years ago, which was in the Journal of the American Academy of Dermatology. That was another one. These are top tier journals. These are peer-reviewed articles. This is not a fringy thing. That can really help. And I'll tell
Yes.
you, and as long as you be gentle, because probably if they're so skeptical, they haven't read anything about it. So you're going to catch them a little bit off guard, but just be like, I read about this. Could you have a look at this? What do you think? And if they dismiss it, then you could say, no problem. Do you think could we still try to avoid steroids though? Because I really don't want to do them. And I think if they're not willing to talk to you at that point, you just need to say thanks and go elsewhere. Because to me, that's just a crummy clinician, right? Anybody who would be dismissive and obnoxious that way, our job is to try to meet your needs. So even if they don't believe it, that's okay because they have the paper now and you can say, here are the things we could try. Just do non-steroidals, and that's great. So
Yes.
you're in the same place as you'd be with me or with anybody who believes it.
Yeah. Oh, that's amazing. We also have the doctor's guide that you were kind enough to help us with. That's written for doctors by doctors, which just says your patient thinks that they are going through this. This is a real condition. Here's some ways to differentiate it. So I think having several different tools, not just something that you pulled off Google, I think that's probably pretty irritating as a doctor to get a whole stack of papers like that. But if we could keep it simple and to the point, maybe that would be helpful.
You're right. It can be. It's hard because if it seems more random, then you kind of feel like you're under attack. You're like, I don't know, and I can't. So I think some
Yeah.
people will be dismissive at that point. So, but I like the idea of I read this paper. Could you have a look at it? It's great. It's
Mm.
hard to it's bulletproof.
That's awesome. Okay, so if patients cannot find a doctor who is supportive of their journey, what do they do?
That, my friend, is the biggest question in American healthcare. I mean, this is a huge, hard question, right? Yeah. I
Mhm.
don't think we have great answers. And this is true for everything. I mean, we talk about this, the same discussion about eczema, the same discussion about hidradenitis suppurativa, alopecia areata. I mean, it's really tough. So where do people go? And the answer is, I don't know. I mean, I think that's why people went to
Yeah,
the internet. It was a cry for help that
yeah,
people really did feel lost. So I think part of it is trying to find a network of people. If there's someone even close by in a state over or a city over, that can be really helpful. I think some of the conferences can also be a place where people can connect. Many primary care doctors end up taking on the role of caregiver in this
right.
situation, even though you'd think it'd be derms. But this is true for a lot of these kind of conditions. And I think that's why Belinda Sherry from Australia, as a general practitioner, became an expert in this disease because her patients felt that many of the dermatologists just didn't buy it or didn't help or didn't want to help. So she took it over. And it makes me sad, but it's the truth. So I think people just have to keep advocating, keep looking, trying to find someone who will, at the very least, they don't have to, again, they don't have to believe it, but if they can at least say, okay, I can treat you for sure without steroids, that'd
Yeah.
be great. I think we're in the same place.
Yeah, that's really good. Yeah, and just to let our community know, we do have a list of recommended doctors from our community. So people who have gone to someone, even if they're not familiar, they may be just supportive of, okay, we realize you don't want to, treat with steroids. Let's find something else. So you can find that in our file section in our closed group on Facebook. But these were all such amazing recommendations and so much good information here, Dr. Leo. Thank you for giving us your time and being so generous as always to just really care about patients and help us move things forward and make the world a safer place for everybody. So appreciate you.
Thank you. Thank you for having me.
Yeah. All right. Thanks.